Hey, good morning. I'm Dr. Stites, Chief Medical Officer here at the University of Kansas Health System. Today, in Open Mics with Dr. Stites, we get to have one of my very favorite shows. We've gathered 10 Chief Medical Officers and infectious disease specialists from across the metro and across Kansas, including myself and Dr. Dana Hawkinson. It's been 4 months since we've had a status report on COVID, so we'll look at that. We're going to see what flu and RSV numbers are looking like. And we're going to help prepare to observe 4 years now of living with COVID. After we hear from our physicians, we will open this up to reporters in the community for any questions. Members of the community should put their questions into the chat feeds in Facebook, YouTube, and the X platform, or email us at the Medical News Network at kmc.edu. Alexis Del Cid will monitor those feeds for those questions. Let's get started. Across the country, according to this COVID data tracker from the CDC, you can see the trends for the positive tests, emergency visits, and hospitalizations, and they all appear to be trending down. And after rising for the past month or so, the trend for COVID deaths is down. Now, here's a look at the national picture in this current heat map from the New York Times. You can see this looks a lot different than it has the last few Januaries. There just aren't very many hotspots, which is awesome. There does appear to be one out in Las Vegas, Nevada. Oh, wait, that's the Chiefs colors. All right, let's bring in Dr. Dana Hawkinson, Medical Director of Infection Prevention Control here at the University of Kansas Health System. Doc Hawk, what are the numbers looking like?
Yeah, well, so we had a little dip in the numbers, which was good, but this week we unfortunately went back up as far as our COVID positive admissions. I think we had gone down to 16. We're at 23 active this week, still not of where we have seen our recent peak of 33, but again, 23 active inpatients. But overall, based on our data from last week, we have seen a decrease in admissions for both COVID and influenza, but also RSV as well. So overall, I think the respiratory virus season right now is a lot better. Seems to be decreasing. Circulation of the virus in the community seems to be decreasing. Hopefully those trends and those numbers continue.
You know, it is nice to see that. It is a better story than last year, and certainly the year before that and the year before that. I mean, as we approach the 4-year mark, you get the feeling this is waning just a bit.
Yeah, I think so. I think it also is becoming more of a seasonal respiratory virus, such as influenza, RSV, the other common cough and cold viruses. Hopefully that trend will stay, but I still do anticipate, and my hypothesis is predicting there will still be a little bit larger circulation of the virus in the warmer months as well, but just not to the levels that we have seen over the winter. So hopefully it is really getting into that seasonality aspect of it.
So let's take a look back last year at this time when we had a CMO news conference then. You can see we had 51 patients in early January. It bottomed out at 3 in July. Well, that was awesome. Then by last September, when we had our last CMO conference, that number had gone back up to 19. Today, the numbers crept up to 23 active COVID cases. Now, if you'd told us this years ago, hey, you're going to have a brand new disease that's taken 23 hospital beds, and it's going to be that way every January, you would have said, well, that's actually a lot, because that's a lot more than we have influenza, so that would have been a big darn deal. But compared to where we were when we had 250 COVID patients, man, it's a whole lot better. But COVID is not truly in the rearview mirror. It may be better, but remember, it's not gone. It's time to hear how COVID cases are looking across our metro and the region. And we are thrilled to have with us today Dr. Lisa Hayes, the Chief Medical Officer at Advent, Dr. Cheryl Beard, the Chief Medical Officer, Ascension Via Christi Health, Wichita, Dr. Kirk Sloan, the Chief Medical Officer at Lawrence Memorial Hospital, Dr. Angela Myers, Division Director of Infectious Disease at Children's Mercy Hospital, Dr. Chakshu Gupta, the Chief Medical Officer at Liberty Hospital, Dr. Kelly Rhodes Stark, Chief Medical Officer at the University of Kansas Health System in Olathe, Dr. Bill Gilberts, the Chief Medical Officer at St. Luke's, and Dr. Kevin Dishon, the Chief Medical Officer at Stormont Vale. Man, I said that really fast. I don't think I screwed up anybody's name. Impressive. Thank you all for joining me and Doc Hawk this morning. Okay, so you guys have seen what the COVID numbers have been like at our health system. Let's see what things are like at other hospitals in the metro and around the region. So I'm going to start right at the top, and I'm going to ask Dr. Lisa Hayes, the CMO at Advent. Lisa, how are things looking in your place?
Overall, much better than a year ago and tremendously better than 2 years ago when we were in the height of Omicron. Today, we only have 4 patients positive for COVID at Shawnee Mission, and we have 3 at our South Overland Park Hospital, 2 RSV and 1 influenza at Shawnee Mission. Typically, we saw a peak about 2 weeks after Christmas, as you would expect. I think we had 14 at our peak on our COVID. We've been very fortunate. Most of the cases have been mild. We haven't had one in the ICU for this week and none on a ventilator, obviously. So things are looking better, definitely.
Yeah, it is a pleasure to be where we are compared to where we were. Dr. Cheryl Beard, the Chief Medical Officer at Ascension Via Christi Health. Cheryl, how are things in your place?
Thank you. Good morning. Our COVID numbers are also fairly low. As a health system, we have less than 10 hospitalizations of COVID patients and low number of associates who are furloughed with COVID. We have no real effect on our supplies and really no differences in staffing related to this. So, much better than where we were. Appreciate it.
It is a lot better, and I know Wichita, you guys had a pretty big outbreak in the height of COVID, and so this is clearly better. Dr. Kirk Sloan, Chief Medical Officer, Lawrence Memorial Hospital. Kirk.
Good morning. Thank you. I'm happy to report that our numbers are similar to what we're seeing out there. We have 6 COVID right now. None of those are very sick. None of those are on ventilators, which is a really good thing. This is significantly less than what we saw last year, and obviously much less than we saw the year before. So I hope this continues to improve as we're seeing.
Yeah, I'm just thinking, man, it just feels like we're at this much better phase of this pandemic and whatever we're calling it today. And COVID has become, to Dr. Hawkinson's point earlier, a seasonal respiratory virus, a significant one. Now, we still have 3 patients in the ICU, but only 1 of those are on a ventilator. So that's really good. Okay, Dr. Angela Myers, we have been talking about COVID a lot. Talk to us about that and how RSV is doing this year. Chief Medical Officer, Chief, I should say, Division Director at Children's Mercy.
Yeah, hi, thank you. So, COVID has not been the big deal that it has been for adults in terms of children. So we've had 4 to 5 children admitted to the hospital with COVID over the last few weeks. But bigger for us has been influenza and RSV, which it always is every year. We're still seeing some steady rates of influenza. We're actually seeing small rises in influenza B as expected later in the season, and a decline in RSV from its peak kind of mid to late December, but still seeing plenty of cases.
Great news. Just as a thought, since we're right here with you and you got the cool arrowhead behind you, this new RSV therapy, both vaccination and monoclonal antibody things, what do you think that's going to do for RSV in kids and how that will impact Children's Mercy?
Yeah, I think it's fantastic. Obviously this year was a little bit of a bust because there was a lot more demand than was anticipated from the manufacturer, and so there really wasn't enough to go around. But I think next fall we're going to see a new game, and it's going to be amazing. The research showed that it prevented hospitalization or decreased it by 80%, which is huge in those first couple years of life. So I think we're going to see a big difference in children getting really sick with RSV and children getting hospitalized by next winter.
Yeah, it's going to be great. That's a really big deal. Dr. Gupta, Chief Medical Officer at Liberty, how are things in your place?
Well, first of all, good morning, everyone. Very happy to represent the Northland in this group. I have very similar things to report as the rest of the chief medical officers in this group have. So we've been pretty stable in terms of COVID numbers. Our test positivity has ranged between 10 and 15%, goes up and down a little bit, obviously higher than the summer and the early fall. But as we get together to celebrate the chiefs and get together in larger groups, this little bit of respiratory illnesses will definitely go up. That's to be expected. Our flu numbers have been a little bit more of a concern for me. They had ranged about 8% positivity for several weeks, and now they have doubled this week to about almost 20% for us. RSV has been up and down, about 7% test positivity. This year is up to 12%. So the numbers are going up a slight bit, as is expected this time of the year, but nothing of major concern. We have less than a handful of inpatients that are sick with these illnesses. None of them are severely ill to be needing ICU care or more critical care, and we are able to safely treat and discharge many of these patients.
Such good stuff. All right, thank you. Dr. Kelly Rhodes Stark, Chief Medical Officer at the University of Kansas Health System in Olathe, Southwest Kansas City market. Dr. Rhodes Stark, how are things?
Well, I would say, first of all, thank you very much. I'm very happy to join this team this morning from Olathe. And our numbers are really mirroring what everyone else is reporting here, but also throughout the state of Kansas and nationally. So we saw the first uptick in our COVID admissions the fourth quarter of 2023. So October, November, December, we went from having maybe 5 patients in the summer overall in a month to 30 to 34 patients in a month in November. And then we doubled that almost in December. We went to 63 inpatients in December. So this just mirrors, as everyone says, those winter illnesses, respiratory viruses, and when people get together and travel. So that's what we're seeing here. We are also seeing, however, the downward trend for January. So for example, our average daily census of COVID primary diagnosis inpatients October, November was 5. In December, it went a little bit above 8. And for January, we'll get those final numbers today, but I think it's going to come in under 5 average daily census for COVID. And in the last 10 days, we're seeing 0 to 1. So a little bit different than what you're seeing there at main campus at UKHS. But we are very pleased. We're seeing a downward trend. We have not seen as much RSV as far as needing hospitalizations, single digits at the most, 1, maybe 2 per month for the fourth quarter, and the same thing for influenza. It is interesting, though, our outpatient positivity rate, if we look at the clinics when they're testing for these viruses, you see the same thing. So COVID in October, 9%. November it went up to 13% positivity, and in December it was 16%. And very similar things with flu and RSV.
You know, it is good news to see the decreases. And let's check in with Dr. Bill Gilbert, the Chief Medical Officer at St. Luke's. Bill, how are things in your place?
Good morning, everybody. Across the 4 Metro St. Luke's hospitals and the 4 critical access hospitals, we currently have 20 active COVID cases. 2 of those are in the ICU and 1 is on a vent. We have 17 active influenza cases, 1 on a vent, and 5 RSV cases that are in the inpatient side. On the outpatient side, like everyone's saying, we're seeing COVID, influenza, and RSV. The CDC reported that the COVID-19 in the wastewater, although those levels are decreasing, they're still higher than they were this time last year or last summer. So we're paying attention.
You know, and we're going to come back to that point. I want to talk about that after we check in with Kevin Dishman. But I do want to talk about this difference and discrepancies from what we see in the past around some of the wastewater testing. Dr. Kevin Dishman is Chief Medical Officer, Stormont Vale Health. Kevin, how are things?
Well, first of all, thank you and good morning. I would echo what all my colleagues have said. You know, we're really, I think, lining up for the triple challenge that we're going to see going forward, which is RSV, influenza, and COVID-19, all being things that we're going to be challenged with in the future. I don't think any of those things are going away, and so we're emphasizing the importance of prevention, continuing to do those things which we learned were so important during COVID, hand washing, hygiene, and using common sense. We did see a notable increase in respiratory viruses across the spectrum during the holidays, as would be expected. We have seen the same decrease as everyone else, with about 7 to 10 on average in the hospital with COVID at this point. But equally important, we're seeing another third of RSV and another third of influenza. We have seen, as Angela mentioned, that we have a significant decrease in RSV this year in our pediatric population. And I think that's attributable to what we're seeing with monoclonal antibodies and better prevention in those areas. So basically seeing the same thing that all my colleagues are across the area.
You know, let's get back to that thing. I think it's an important point here in the midst of this public health crisis still is that wastewater testing shows a rise in some of the, and it's been high for a while, yet admissions are down. Kevin, what do you think?
Well, I just think we're seeing a spectrum of disease, and we're not seeing as that this is as intense of a form of the virus as we have seen in the past. And it's as we said throughout the last 4 years, this is just going to become part of a respiratory virus that we have to face going forward in the future. And hopefully what we're seeing is that the response to it is less intense. But I think it is becoming more prevalent in our society.
You know, that's my sense, Hawkeye, is that between vaccination and recurrent infection, we're just in a better place than we were.
Mm-hmm. Yeah, absolutely. This, infection, really this disease, especially the severe and hospitalized patients, really continues to be more of a disease of those most at risk. And was actually just looking at a study in the last couple days, about those people most at risk, and it looked at Paxlovid. We still have one more tool that we can utilize probably more, and they estimated that we could save up to 850,000 hospitalizations and over $170 billion in savings if we had better use and expansion of Paxlovid, especially for those most at risk as well.
Yeah, I think it's always important to remember we do have therapy.
Yep.
Now, there have been at least 4 states that have reinstituted mask mandates amid a rise in COVID. Bill, have you guys thought about that at all when things are starting to rise? Did you tease that idea out at St. Luke's?
We have talked about it, but at this point, we have not changed our policy as far as masking. Certainly, if we have a positive COVID patient, we expect everybody to mask around that individual or someone that's suspected COVID infection, but we are not doing mandatory masking. That said, we do have a number of clinicians and nurses that mask routinely as their personal choice.
Yeah, I like that. That's a great point about the personal choice. People don't always do it. And I think when you're around loved ones, whether it's a question of influenza, RSV, or COVID, or any of the metapneumovirus or adenovirus or whatever, if you're sick, wear a mask. You don't want to give it to somebody else. I do believe we've talked many times about the rules of infection control. Yeah. They still help you wherever you go, Hawk.
Yeah, that's absolutely right. And I don't know if we'll be talking about it on this show or not, but there was a recent clinical infectious disease study also that looked at PPE, personal protective equipment, but also IPAC practices in the hospital. And what they showed, they actually had pairs of people who were sick and viruses and the genomes and things like that. And out of 120 pairs, when they compared all of those things with people who were working in the hospital and positive for COVID, what they found, and they were also testing the patients that they were seeing as well, is that only 10 of those occurred with transmission within the hospital. So the vast majority of those people were getting COVID outside of the hospital, showing that those PPE, those infection prevention practices, did help to significantly reduce your chance of infection as well.
Dr. Myers, what about children's? I mean, you guys, there's just so much more RSV that comes to your place and things. How are you all approaching masking and infection control at Children's Mercy?
Yeah, we're not having mandatory masking much like the other places around town, but many people are continuing to mask when they're working clinically, again, per their own choice. But we have a very wonderful infection control program here for all of the children who are admitted with respiratory illnesses and are obviously in isolation, and we are wearing all of the PPE to protect them, to protect ourselves, and protect the rest of our patients.
Yeah, I think that makes sense. We've tried to do it a little bit by unit, and some of our units are most fun. The BMT guys never stopped masking, but our rehab facility, they went to masking for a while because they had some staff go out, and obviously that's a very vulnerable population. So it's a little bit different. We've tried to be a little bit more selective in how we've approached that. I wonder, one of the things I know in the height of COVID, we had that mission control app that showed how difficult it was to do with around transfers. Dr. Cheryl Beard is the CMO there at Ascension Via Christi in Wichita. Cheryl, are you guys still seeing the same struggles around the transfer centers and getting patients into beds, et cetera? I know we still are having that problem because of just a lot of patients in beds.
Yeah, so we are staffed to the ceiling with patients, and so it is difficult to take some of those transfers. We do our best to take those phone calls and try to manage them. For some of our programs, we don't go on diversion for burn as an example, that we really try to accommodate our regional hospitals with transfers in.
Yeah, it is a big deal, I think. And so, Dr. Hayes, supply chain, let's hit on that. I think you mentioned that the supply chain is a lot better than it was, but we saw some real shortages for a while. Even the meds appear to be easing. We don't see it. For a while there, we were running out of things like Versed or Propofol, and that seems to have really gotten better.
I would say overall it's much better. I still hear occasionally of shortages. Like I know that there's a shortage on Rogam for pregnant individuals who are Rh negative. I also know, I think we had a shortage of lorazepam recently. So it just seems to be hit and miss here and there, but it's definitely better than it had been a year ago.
Yeah, I thought you said Rogaine there for a minute. I thought I was going to lose even more hair. Oh, wait, I've already lost my hair. I think I'll be on help on that one. So if we talk about things in a community like Lawrence with all the students and things of that nature, Kirk, any changes you're seeing in the student population? I'm betting it's kind of behavior back to normal at the University of Kansas.
Yeah, I think things have really headed back to normal. I think, a lot of us have had our fill of the pandemic and the changes that brought, and so people are heading back and acting the way they used to be. I'm hoping that they're a little more cognizant of the risks out there, and especially when it comes to COVID and those types of things. But, it's lucky and it's rare for us to hospitalize students because they're young and they're otherwise healthy. I think they have that going for them.
Dr. Gupta, I believe that you're a pathologist by training, and one of the things a lot of people are trying to figure out is what is going on with long COVID. Have you had the chance to take a look at that and think about that from the anatomic pathology viewpoint, and what are we seeing?
Well, that's a little bit of a complicated question for this group, but yes, so there is a lot of long COVID going on, and there's a multifactorial etiology to long COVID. I think the most important thing for this forum, because it's directly impacts the community, is to ensure that they vaccinate and they mask, because the symptoms of long COVID, which do affect a subset of patients that do get COVID, can linger on for months to years. Multifactorial etiologies include long-term damage due to the antibodies that are made against the virus that damage the tissue and the cells, and the response that we have due to that. There are also some long-term neurological things that are now coming to light in terms of COVID, that people struggle with their memories or some neurological deficits. But the important, I think, fact remains is that prevention is the best part of this respiratory illness. So mask, try to avoid crowds, especially around the Super Bowl. If you have someone who has a chronic medical condition or is older or even younger, those little kiddos, if you want to wrap them in those beautiful onsies with the number 15 on their vest, well, they can't mask. Those little kiddos cannot mask. So keep them away from large crowds, and certainly from someone who's been sick.
All right, well said, and a good reminder to us. Now, Dr. Rhodes-Stark, spring approaches. What does your crystal ball tell you is going to come about this spring?
I think we're going to see the downward trend that we have seen last year, particularly here at our hospital. And, I just wanted to say, we've talked about how it seems that vaccines and the immunity just from infection and reinfection have decreased the severity of COVID, which is a wonderful thing. But we also have to remember, we have to continue to educate our patients and their family members that we do still have those high-risk patients. I live in the world of oncology here at the Cancer Center. I'm a radiation oncologist. And cancer patients that are actively receiving treatment, particularly chemotherapies, certainly transplants, et cetera, they are uniquely vulnerable to having the severe side effects with COVID. And, there are some studies that say it's multiple fold. So these are patients that are at the highest risk of having hospitalization and death, along with other patients with severe lung and heart disease, kidney disease, et cetera. So I do think that we celebrate what has happened in the communities, that we see that this has become less severe, less deaths from COVID, but that we also have to continue to educate, particularly about vaccines and masking, and at the height of the season, really impart that information to our patients. I think that's our responsibility.
Yeah, I think that's exactly right. And, we have to remember that 4 years ago, we didn't have COVID, and today our COVID census is generally, at least in the adult hospitals, about twice the influenza, or maybe even twice influenza plus RSV. So it's not like it's gone, but it is a lot better. And Hawk, I talk about the program too. The importance of vaccination cannot be overestimated. I'm old enough, so I'm probably the old enough guy up here. Maybe Bill and I are about the same age. Sorry, Bill. But as we reflect back on it, people talk about, maybe we don't need to do vaccination in kids and things like that. It scares me a little because I saw the effects of polio, especially in my earlier days. You would see patients who were post-polio coming into the ICU with trouble breathing, and they'd had polio 20 years ago. And we don't have to see that anymore. The thought of bringing that back, I just think that's a terrible idea.
Yeah, I think we're always going to endorse the safety and efficacy of vaccines, especially these vaccines that have been around for decades and have shown and proven to be safe and effective. And I think we have a little bit of recency bias. We don't understand the devastation, the morbidity, the mortality that generations before us prior to these vaccinations went through, especially those children that had to deal with those diseases that primarily affected children. Unfortunately, we know that there are outbreaks that occur all the time, measles, mumps, things that are easily preventable by vaccines. So I think it's vitally important to continue to, number one, investigate the vaccines, have that transparency. We do have that with COVID vaccines and the other vaccines. We have plenty of programs that help identify side effects or problems with those vaccines, but then also continue to endorse the fact that they are helping to prevent your child and you, when you get these vaccines, also from illness and death. And we know that it's continuing to be a problem fighting misinformation, but it's vitally important to continue to endorse those and get your children vaccinated. We do hear commonly, and probably 1 or 2 stories every year, about parents who unfortunately have lost a child because they did not get their children vaccinated against influenza. So that's just a common thing we deal with, not even the other previous illnesses like you talked about, polio, measles, mumps, things of that nature. So certainly we'll continue to endorse the use of vaccines as well.
And Dr. Myers, I got to turn back to you. We're talking about kids a little bit. That idea of not vaccinating children, ouch.
Yeah, so Steve, I'm so glad you mentioned this, because we just recently had an adult with measles in the community who exposed young children who were too young to be vaccinated, and we needed to try to provide post-exposure prophylaxis to those infants. Unfortunately, then we were unable to get IMIG because we had some pretty severe weather and it was unable to be flown here on time. So there are a lot of issues around not getting vaccinated and making sure that we are protecting the youngest ones in our community.
Yeah, I think that's right. I think Hawkeye said exactly right. That recency bias, we forgot how bad it was because we haven't had to live it. I've been here long enough. I had to live the side effects of patients who'd had polio in the 30s and 40s, and I got to tell you, you don't want to do that again. That is a mistake. I'm going to turn to Alexis Del Cid and see what questions have come in from community and/or reporters today.
We have plenty of questions coming in from the community. Sharon Chapman Whitlaw wants to know if the RSV vaccine will be yearly, like the flu vaccine, or if it's going to be one of those shots that you get once and you're done.
Dr. Myers.
So the RSV monoclonal antibody is given one time for all infants under the age of 8 months during their first RSV season. Those infants that are high risk related to congenital heart disease or other issues are able to then get a second dose in the second season.
And Hawkeye for adults, what do you think? It's over 60 now, but man, I think there's need under 60.
Yeah, right now I believe the data supported a 2-year interval of getting it. So I think that's what the recommendation is at this point. If you got it, I think it does have activity through 2 RSV seasons.
So I can do that. I'm going to just do it every odd year because let's face it, I'm odd and it works, Alexis.
You're unique.
Yeah,
Dr.
that's true
Stites.
too.
You're not
uniquely odd. Yeah.
You're our favorite character. And we love you. Yeah. A question from Amy Handelman Bennett. Amy wants to know, what are you seeing, or are you seeing vaccine reactions? Because Amy writes, I'm 3 years since my second vaccination with my intractable migraines. I know my neurologist has tried everything. Thank you for all you are doing.
Kevin, I've not seen that type of complication. I know people have different thoughts about that, but I'm just, vaccination in general is pretty safe. I don't know about migraine specifically.
No, I haven't seen that either. I think, of course, the best advice is to always speak with your family physician, and they certainly can seek out opinions from specialists, but can underscore the importance of getting that vaccination and ensuring that you're appropriately protected as a part of your armamentarium when you're ensuring that you're not getting this virus in the first place. So my recommendation would be speak with your primary care provider and develop a plan that would allow every opportunity to be vaccinated.
So to put a finer point on that, you're not seeing vaccine reactions related to migraines, is what Amy was, I think, getting at.
I haven't seen that either.
Okay.
As you said, Dr. That's not been in my experience.
And I just have to say, there's so many things that trigger migraines, and it's sometimes hard to know any medication, a change in diet. I mean, it's hard. When we look at the vaccine side effects, there are things you go, well, maybe this, maybe that. I've not heard, maybe a little bit of myocarditis if you're a young man or something like that for a brief period, self-limited, doesn't make any real impact. But I've not heard about migraines per se as much.
Yeah, no, I think that's right. And I think to your point, too, is as we are now farther out from, number one, when the pandemic first started and so many people getting infected and reinfecting, but also now people receiving multiple doses. I think it's going to be hard to tease that out, but haven't heard any great or significant data about triggering migraines itself. What we do know is that it can help reduce your risks of other problems. Number one, with infection, which we know causes a high rate of blood clots and other complications. Recent study from the VA that showed those people that were at highest risk, meaning older age, but also they looked at people who had end-stage renal disease who are on hemodialysis, and actually receiving the vaccine helped reduce their risk of blood clots when they did get infected as well, probably by about 50%. So again, more benefits than risk and safety events, but we'll continue to evaluate safety events.
It's interesting. I've talked to some patients who said, well, I got the vaccine, it caused that. They'd also gotten COVID, but they chose to blame the vaccine, and the reality is it's probably more likely to be part of long COVID. Alexis.
To that point, when I got COVID, I had horrible headaches from the COVID, and I had been vaccinated. Okay, Marie has a question about babies getting vaccinated. Marie wants to know, are you recommending babies get this vaccine? It says 6 months and up. I'm a new mom, and I'm apprehensive about vaccinating my newborn. What would you tell Marie?
Well, Dr. Myers, you're the person to answer that one for sure.
Okay. Yes, Marie, absolutely. I understand the fear of being a brand new parent and thinking about getting all of these vaccines for your children. But here's what I will tell you. I know you want what's best for your child, and I promise you, so does your pediatrician. And all of the vaccines that we give in that first year of life have been shown to be safe and effective. And when given together, we do the best job of protecting your child as soon as possible. So we always recommend that we do them on time as they're recommended, so that we can get your child the best amount of immunity as early as possible.
Steve wants to know, for some clarity, are you recommending a spring booster then in 2024?
Yeah,
what is the clear recommendation?
Yeah, Dr. Hayes, I think the recommendation for most patients has been once a year now, and not a spring booster unless you're immunocompromised. Was that what you're seeing too, Dr. Hayes?
Yeah, I haven't seen any recommendations that would say twice a year, but I'll defer to the infectious disease specialists on that one.
Yeah, Steve, I think you're exactly right. Those people with severe to moderate immunosuppression, they do have a list of that on the CDC website. If you are getting immunosuppression, you're probably going to be seeing a medical team or a physician quite regularly. Speak with your physician. But just as they had before, those people with severe to moderate immunosuppression do have, I guess, the ability, but the CDC does say that it's okay to receive a second dose at least 8 weeks after that first booster dose. So again, speak with your medical provider to really tease out and get all your questions answered.
Wendy has a really good question about PCR tests. Wendy wants to know if it's possible for a PCR test to give a false negative. Here's why. It's a long question, but basically Wendy shares that she and her entire family all got sick with the exact same symptoms. Everyone tested positive for COVID except Wendy, but they had the same loss of smell, loss of taste, fever, so she was stunned that hers was negative. Is it possible that was a false negative?
Sounds like it was definitely a false negative.
Yeah, absolutely. Again, these are tests. They have inborn error in the test itself, whether it's the reagents, what we're using to do the testing. It could have been a human error in getting the sample. But certainly, we know that with all the tests, and this is something Dr. Stites and I and all of our physicians here have to deal with whenever we order tests, is what is the likelihood of a certain result, either positive or negative, based on the patient, and then what do we do with those results? So it sounds, just as you said, Steve, based on all the symptoms, that it was a significant, or it was a false negative. And again, you know, it's less likely with a PCR test compared to the at-home antigen tests, but it certainly can happen as well, and so I think we have to understand that.
And Dr. DeGupta, you see this in the world of laboratory medicine, that there are challenges sometimes, even when you're certain somebody has a disease.
Yes, I think everything that was just said by Dr. Hawkinson is spot on. So when we see, so PCR tests, they actually amplify every piece of your DNA several million-fold. So their sensitivity is very, very high. So when these tests are negative in a person who is symptomatic and very likely clinically to have the disease, the chances are the sample was incorrectly collected or transported. Most labs have very robust quality controls, so it's unlikely that something happened in the lab, and it's most likely something happened before the lab during collection or transportation. It is also possible that you did not have COVID and have some other disease that mimicked COVID symptoms. So if you have what you feel is a false negative, always a good idea to have a second test done to confirm that. Remember, PCR picks up pieces of your DNA or RNA of the COVID virus, so they will remain positive for a long time. So it's not unreasonable to have the test repeated if you really want to confirm the condition.
All right, Alexis.
I have one more question. This is from Alex, and this is on behalf of all the people who've gotten COVID more than once or twice, because they're out there. Alex writes, I've had COVID 3 times. I am fully vaccinated, up to date on my boosters. My COVID, though, was severe each time. Does that mean I'm more at risk for long-term heart or general health problems?
That's a great question. Doc Hawk, what are you thinking?
Yeah, I mean, I think we have to define what do you mean severe, meaning you felt pretty bad for a few days or a week, or severe as we term severe when you're in the hospital in the ICU. I'm going to say that it was severe because you were at home feeling pretty bad for a few days. I don't know that having it multiple times, nor being symptomatic for it, is going to put you at any further increased risk down the line. We know that some people who have had COVID do have some sort of increased risk of things like diabetes and maybe heart problems in the short term, but I don't think that in your case, from the question that was asked and how I'm interpreting it, that you would be at any other further increased risk compared to somebody else.
You know, it reminds me of influenza. I've had influenza probably 4 or 5 times. And you know what? I feel terrible every time I have influenza. And I get vaccinated. I still get influenza. I feel terrible. So I don't think it means that I'm going to have an increased risk of death or that I'm going to badly. And I think we have to remember COVID is a respiratory virus like influenza. Don't expect it to act differently in terms of how sick you're going to feel. What you might want to think about is how sick you might feel if you've never been vaccinated, never had it, a new variant comes out, and it's the first time your body's ever experienced it. That may be a different question. But feeling sick from a bad virus, well, that's how they make you sick. All right, this has been a great program today. First of all, I can't tell you how much I appreciate the work of this group of people and their health systems and hospitals that they represent throughout the pandemic. We're often terrible competitors, but at the end of the day, we are all rowing against the same disease and trying to improve the health of our community and working together to help keep you healthy. And that is the heart of medicine. And what you've heard today is also the heart of hope, faith, and science when it comes together and finds new therapies and for people to work together to help keep you safe. We'll check in again in a few months and see how things are going around. But I do want to say a great thank you to all our chief medical officers, infectious disease experts, and others who've been on this program today. We are committed to your public health. We're committed to keeping you healthy. And we look forward to seeing you the next time we gather again. Thank you.
It had been 50 years since a Kansas man had been to see the doctor. He made an appointment, finally, because of his dog. I'm Alexis Del Cid on the next All Things Heart, how man's best friend led to a life-saving diagnosis and treatment.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.